Welcome back, everyone. We're going to go through the conditions within the cardiovascular system. Now, we're only going to talk about two major ones. The first one is hypertension or high blood pressure, extremely common. And then the second one is ischemic heart disease. We're going to go through a generalized depict of each of them. We may sort of swap some components of it or weave them in to be discussed together, but essentially we're going to go through all those components. So we'll start with hypertension, really common condition. Essentially, this is high blood pressure. In order for someone to be diagnosed with high blood pressure, it really does depend on a person's medical history. So the cutoff for when we treat and when we actually diagnose someone as high blood pressure, the cutoff is dependent on medical history. For most people should have a blood pressure when treated if they have high blood pressure of under 130 over 80. But we don't start treatment necessarily at that moment. But most, it's anything, most target pressure after treatment is less than 130 over less than 80. But that really depends on the individual. When we look at the etiology of high blood pressure, this is where things get a little bit funny because we don't really know what causes most high blood pressure. Etiology is, for the most part, is generally unknown. So we can actually separate high blood pressure into people who have high blood pressure without any other underlying condition or on any medication that would cause high blood pressure. Or we can separate it into people who have high blood pressure as a result of something else, some medication they're taking, some herbal supplement that they're taking, or some other medical condition that causes their blood pressure to go up. Blood pressure that has no underlying medical condition or drug that causes it is referred to as essential hypertension. Sometimes this is also referred to as primary hypertension. 90% of people who are adults who come in and they have high blood pressure have this type of high blood pressure. It's around 90, even greater than 90, greater than 90% of all high blood pressure. And when we look at the etiology of this, we have no idea. We have no idea what causes it. No known cause. However, we do know that there are risk factors associated with this. The risk factors genetics. So a family history of high blood pressure might predispose someone to having a higher chance of developing it. The older you are, the more likely you are to get high blood pressure, so higher age. Gender differences do exist. Men are more likely than women to get high blood pressure. People who have sedentary lifestyles, sedentary work, are more likely. Poor diet, stress, high stress, one's life can do it, and a risk factor for pretty much every condition, We've talked about it pretty much every single time, smoking. These factors don't necessarily mean that you're going to get high blood pressure. It just means that you have a higher chance of it if these risk factors are present. That's for essential hypertension. There are a minority of cases where we do know what causes it, where it is related to either another medical condition or a medication that someone's on, whereby the side effect of that medication or an unwanted effect of that medication is it raises blood pressure, or one of the clinical manifestations of that condition is that it raises blood pressure. In those instances, we refer to those as secondary hypertension. And the causes of this are varied, but I'll give you an example of this. What secondary hypertension means is that the cause or the etiology can be identified. Example of this, certain drugs and medication can do this. Drugs, example, drugs and medications. So let's say, for instance, that somebody does cocaine. If someone uses cocaine, cocaine acts on the sympathetic nervous system. It acts very similarly to a strong epinephrine. It allows epinephrine to work for a very long time, and it will cause increased resistance in the blood vessels. And this can increase blood pressure. This would be an instance where we know what's causing the high blood pressure. Another thing that can lead to secondary cause of hypertension is a condition known as obstructive sleep apnea. This is where the soft tissues in the back of the throat and the neck relax during sleep, and it blocks off the airway, and people wake up many, many, many times, sometimes dozens of times per hour, and they don't realize that they're waking up that much. But every time that they stop breathing, it activates their sympathetic nervous system, and it causes their heart rate to go up, it causes their blood vessels to squeeze, and it increases their blood pressure. Kidney disease can also do it. And it's related to that angiotensin, renin-angiotensin aldosterone system that we talked about in the previous video. So most causes of high blood pressure, unknown, no known cause. And if we can identify the cause, it is referred to as secondary hypertension. When we look at the epidemiology of high blood pressure, it's really common. About 1/3 of adults in the US have high blood pressure. And if you actually look at adults over the age of 65, it goes up to about 50%. 1/2 adults greater than 65 years. One of the problems with high blood pressure is that it's mostly asymptomatic. It's often called the silent killer because there are no signs or symptoms. And it's usually going to exist for a very long time if you're not checked, your blood pressure isn't checked. So the investigations that are done for high blood pressure, we're going to go there next, are blood pressure checks. Anytime that you go to your primary care professional, your family doctor, your nurse practitioner, whatever that happens to be, for any reason, they should be doing a blood pressure check. Investigations, so blood pressure checks. So that would be at your GP's office, your nurse practitioner's office, whoever that is, they should be doing it. And if there is high blood pressure, the only thing we can really do is rule out that there isn't some underlying medical condition that's causing it or underlying drug that's taken or herbal supplement that's taken, because otherwise we'll never find the cause. So the investigations are used to rule out secondary. I'm going to put a little 2 with a degree sign for secondary causes. So we'll check the kidney to make sure that the kidney is okay. That often includes an ultrasound of the kidney. I'm going to actually write out the word ultrasound. We often short form this to U/S. We can do some blood work. On the blood work forms, the kidney tests are generally some of the electrolytes, but the kidney function tests are things called creatinine and something called BUN, which stands for blood urea nitrogen. These two substances are excreted by the kidneys. They're filtered by the kidneys get rid of them. And so if the kidney's not filtering very well, they build up in the blood. And if somebody's kidney function isn't good, their creatinine rises, their BUN rises, and we can tell that they have kidney issues. We'll also do some heart tests to look at the effect of the high blood pressure on the heart and to rule out any cardiac problems. There are 2 tests that we generally do for people with high blood pressure. We do an ECG, which is checking the electrical conduction within the heart. And we do something called an echocardiogram. Echo, think of sound. Sound waves are done with ultrasound. So this is a specialized ultrasound of the heart. So they take pictures, cardiogram, and it's through sound or an ultrasound. Ultrasound of heart. Here we're actually going to look for the ventricle wall thickness. If blood pressure is really high for a very long time, the heart has to work harder to pump that high pressure blood out of the heart. And when it works harder, it can get really thickened. While initially that thickened muscle will be able to generate more force. Problem with a thicker ventricle is that it becomes really stiff, and the ability of that ventricle to fill with blood goes down because not only does the chamber size get smaller, but also just the stiffness of the ventricle increases. So we check for ventricular wall thickness because that can affect the cardiac function. In general, our clinical manifestations of high blood pressure, it's mostly asymptomatic, as I mentioned. Mostly asymptomatic. If blood pressure is extremely high, and I'm talking about dangerously high, if dangerously high, it could result in a headache. It could result in blurry vision. The reasons for this I'm not going to get into. Could result in chest pain. If you're interested in this, I encourage you to read about these topics. And it could result also in signs and symptoms of a stroke. So it can lead to a stroke. It can cause a headache, blurry vision, chest pain, which would be similar to a heart attack. Somebody can have a heart attack from blood pressure that's too high. When we think about how we can actually treat high blood pressure, it's a little bit tricky. There are a lot of medications that we use because we don't know what the problem is. We know how to lower blood pressure. We have lots of medications to lower blood pressure, but it's really hard to pinpoint exactly what pathway to target because it may not be from that pathway that the blood pressure is elevating. So there are a couple of ways that we can actually treat high blood pressure. And the first way is through pharmacologic techniques. So from a pharm perspective, the first way is to reduce the fluid in the bloodstream. Less fluid pushing up against the walls of the arteries means less pressure. Okay. And the typical way that we do this is through a diuretic. Makes you pee more. Diuretics make you pee, so that fluid, instead of staying in the bloodstream, is being eliminated in the urine. The specific type of diuretic that we typically use is under the category of a thiazide. It works on a very specific transporter within the kidney, and it allows for more water to stay in the tubules of the kidneys and then eventually get to the bladder so that it will be eliminated. There are a couple of there's actually one thiazide diuretic that we don't use anymore because it actually increased risks of non-melanoma skin cancers. We don't actually know why it did this. There was a signal that was seen in the safety data, the post-marketing surveillance that is done through Health Canada that demonstrated that there was an increased risk of these non-melanoma skin cancers. So we stopped using it. And that one, and you can read about it, is a medication called we don't use this one anymore. I'm going to very specifically write this out. We don't use a specific one called hydrochlorothiazide anymore due to increased risk of non-melanoma skin cancer. The actual mechanism of that, I don't know. I'm wondering if anyone has postulated something, but I'm not aware of any reason why it would lead to that. So we use a longer acting one now that doesn't have that same signal. The second way that we approach treatment of high blood pressure is we can actually start by just using this formula, MAP equals cardiac output times resistance. If we can figure out a way to reduce cardiac output, it's going to reduce our blood pressure. And so remember, cardiac output is equal to stroke volume times heart rate. If we reduce our stroke volume, that means we're reducing the amount of fluid that's going into the heart and getting pumped out per unit time. That would be the action of a diuretic. Would reduce our stroke volume because we're reducing the fluid in our intravascular space. We can also modify our heart rate. If we reduce our heart rate, the reduction in heart rate means a reduced cardiac output. And if we reduce our cardiac output, that reduces our mean arterial pressure. So the mechanism we use is we block a very specific receptor that is important in our sympathetic nervous system function. And the specific receptor that we block is something called a beta receptor. So the medication that we use is something called a beta blocker. This is going to reduce heart rate, means that you reduce cardiac output, means that you reduce mean arterial pressure. And that's what we want. You can always recognize beta blockers because their generic names all have a very similar suffix. So there'll be something with the suffix OL, all. So examples of a beta blocker would be bisoprolol, metoprolol, atenolol. If you see that all, that is a beta blocker. So we can use diuretics. We can use beta blockers. So diuretics, beta blockers. We can also use medications that reduce the resistance within the arteries. They dilate the arteries. They don't squeeze it, they actually relax them. So we can relax smooth muscle in arteries. And the specific one that we tend to use is something called a calcium channel blocker. There are different types of calcium channel blockers. This is not a pharmacology course, so I'm not going to go into the nuances of the different types, but we can use calcium channel blockers. Sometimes these are called CCBs. Calcium is absolutely necessary to get contraction of muscle of any kind. And this one specifically acts on the calcium channels within the smooth muscle of the arteries. Those are some of them. We can also target that other pathway that we looked at already, which was in the kidney, target the renin pathway. So remember there was that angiotensinogen to, I'm going to just put Ang1 to Ang2. And this is going to increase blood pressure. Remember the substance that was going to allow for this conversion of angiotensinogen to angiotensin 1 was renin. And the enzyme that would allow for the conversion of angiotensin 1 to angiotensin 2 was ACE, angiotensin converting enzyme. We can block the pathway along any of these. So there are medications that will block the action of renin. So these are, they block renin. Medication name is called Razolez. You can also block the angiotensin converting enzyme. So let's block that. And this is with a medication called an ACE inhibitor. Sometimes it's just denoted ACE with a little I. You can always tell that a medication is an ACE inhibitor because it ends with the suffix pril. So it'll be something with pril. Ramipril, enalapril, captopril. These are all ACE inhibitors. So example, Ramipril. The last place that you can actually block this pathway is you can actually block it directly at the site where angiotensin 2 would bind. And this would be, you'd block the receptors for angiotensin 2. So you can do angiotensin 2 receptor blockers. These medications end with the suffix sartan. So olmesartan, candesartan, those are all medications. So would be an example, candesartan. The ones that we tend to use the most because they have the most they have the most evidence behind them, are the ACE inhibitors and the angiotensin II receptor blockers. The angiotensin II receptor blockers are often short form is ARBs. We call them ARBs. And if we look at the action of, or the effectiveness of ACE inhibitors versus ARBs, they are equally effective. So the decision to order one over another one for somebody with high blood pressure is health professional dependent, whatever they're most comfortable with. I will tell you which ones I'm most comfortable with when I've prescribed these in the past. I am most comfortable with ARBs. And the reason why I'm most comfortable with ARBs is that they have a better side effect profile. One of the most serious adverse outcomes of an ACE inhibitor is a a condition that's known as angioedema that will cause swelling of the lips, swelling of the eyes, swelling of the throat and tongue. And it's specifically related to ACE inhibitors. They literally call it ACE inhibitor-induced angioedema. That does not happen with ARBs. You can't get it with ARBs. There's a whole biochemical pathway that is postulated around why you can get ACE inhibitor-induced angioedema, and it's all related to a pathway with a molecule known as bradykinin that can lead to intense inflammation and edema. The other thing that happens with ACE inhibitors compared to ARBs is that ACE inhibitors can lead to a really nasty, dry, chronic cough. ARBs, it doesn't do that. And the thought is that it's actually it's related to that bradykinin again, but just not as intense of a response to that bradykinin. So side effect profile, I'm going to put query better with ARBs. I think so. I think so, but it depends on the comfort of the practitioner that's prescribing it. When we look at the complications associated with high blood pressure, complications, there are a few. High BP. It increases damage to arteries and accelerates atherosclerosis. That's one of the reasons that high blood pressure is associated with a higher risk of stroke. When we talk about heart attacks and ischemic heart disease, it's also associated with a higher risk of that because of the increased risk of atherosclerosis. It carries with it, high blood pressure carries with it an increased risk of heart attack and stroke. The high blood pressure can damage the small little capillaries within the kidney, and it can lead to kidney failure and kidney disease. Due to damage to small capillaries in kidney. Those small capillaries, it's called the glomerulus. And then the other thing is that the heart is going to work overtime to try to pump that higher pressure blood elsewhere in the body. So over time, that wall thickness of the ventricle is going to increase due to hypertrophy. And the place where we see it the most, because this blood pressure is in the systemic circuit, we see it in the left ventricle. So we get an increased thickness of the left ventricle due to increased work to pump blood into a high pressure aorta, and arteries. What this leads to is wall stiffening. It leads to decreased chamber size. And therefore, you can't effectively pump the amount of blood that you need to. And eventually, what ends up happening is that a person goes into heart failure. Essentially, all the blood is going to back up and it backs up into the lungs. And people get fluid accumulation in their lungs as associated with it because the blood is just waiting to get pumped out, but it can't because the wall is too stiff, the chamber size is too small, and you end up with a backup of blood. That's all I really want to say about high blood pressure. I think that's enough to give you an idea about what you might see. Some of you will probably work with high blood pressure in some capacity in your career. There are new medications and new cocktails of medications that are tried all the time. And there are trials going on with high blood pressure. So some of you may be involved with that. The second type of illness within the cardiovascular system that I think is really important to talk about is something referred to as ischemic heart disease. Sometimes this is just referred to as IHD. And this is almost always related, not always, but almost always related due to blockages in the coronary arteries from atherosclerosis. And so when there are blockages in the coronary arteries as a result of atherosclerosis, we call that coronary artery disease. So sometimes that's called CAD, and this is from atherosclerosis. The problem with the heart is that every branch of the coronary arteries, whichever branch you're looking at, the area of heart muscle that coronary branch supplies is only supplied by that artery. There's no alternate blood flow. So if you block off that artery, that piece of heart muscle will die. And that's what is going to lead to that ischemia, that reduced oxygenated blood flow to the heart. And eventually, the heart muscle will die. So there are several types of ischemic heart disease. So actually, before I get there, I better write down that it's due to coronary artery disease from atherosclerosis, and it results in decreased oxygenated blood flow to the heart. There are several types of ischemic heart disease. This is an umbrella term. There is a type of ischemic heart disease that they call chronic. This is going on for a long time. And the specific type that we're going to talk about in the chronic ischemic heart disease is something called stable angina. If there's chronic, there's also acute. This is going to be a sudden happening, and these acute ones are all medical emergencies. It requires treatment immediately. There are two types of acute ischemic heart disease that we'll talk about. If there's stable angina, there's a form that is known as unstable angina. And I'll tell you what that means. Angina, AN. And then the second one is specifically when that heart muscle actually dies. And so the heart muscle dying from ischemia, we would call a myocardial, so heart muscle. And death of tissue as a result of ischemia is infarction. Infarction. So this is sometimes just called an MI. We call this an MI all the time. We'll talk about all of these, but before we do, the cause of this is generally atherosclerosis. It doesn't always have to be atherosclerosis, but it usually is. Etiology is atherosclerosis. And there are a lot of risk factors for this. Basically, they're the same risk factors that are associated with stroke. So high blood pressure, problems with the cholesterol, so high bad cholesterol, LDL, and low good cholesterol, or HDL. Diabetes, we talked about the macrovascular complications of diabetes. That was an accelerated atherosclerosis of the coronary vessels and cerebral vessels. Obesity is associated with it. These are risk factors: obesity, sedentary lifestyle, age. Men are more likely to get it than women. You guessed it, smoking. And then there are these processes that happen in the body that tend to accelerate atherosclerosis more than if none of these risk factors are present. And they're any kind of inflammation within the body, inflammatory processes. I'll explain what I mean by that. There are a few conditions that increase risk of coronary artery disease. One of them is psoriasis. People who have psoriasis often have an accelerated atherosclerosis associated with it. The inflammatory process that's happening in their skin, sometimes their joints, can also happen within their blood vessels. Rheumatoid arthritis is associated with this. Rheumatoid arthritis is an autoimmune condition that leads to inflammation essentially throughout the body, but it's most notable in the joints of the hands, as well as any other joints in the body. The other one is lupus. It's also an autoimmune condition that essentially where the body's attacking itself, and it leads to a generalized inflammatory process going on in the body. When we talk about the pathogenesis of ischemic heart disease, it's really related to that plaque formation from atherosclerosis. I'm not going to go through the entire pathogenesis of atherosclerosis again, but it's essentially you have that blood vessel, with that plaque that narrows the lumen of the artery. So this would be, in this case, this would be a coronary vessel, and there is a reduced blood flow. And that reduced blood flow may lead to ischemia. Sometimes that plaque there can rupture. It can rupture. So there's that plaque. It can rupture, and it can fully block off the flow of blood, which it will also lead to ischemia and then eventually death. But it doesn't necessarily have to be broken in order to block the flow of blood. You can still have a little bit of blood flow, and still have symptoms of ischemic heart disease without it actually fully blocking it off. So when we look at the actual clinical side of things, clinical side of things, we're going to start with this chronic ischemic heart disease, specifically stable angina. What's happening in stable angina is that you have your blood vessel. The lumen is narrowed because of that plaque that's there. It's there. And so there is blood flow, but it's less. So this would be a cross section of the blood vessel. During times of rest with stable angina, the heart muscle is getting the proper amount of oxygen that it needs. But during exercise, that blockage is fixed. You can't get any extra blood flow to the heart. So during exercise, when the heart needs more blood flow but can't get it, it starts to go into a bit of ischemia. So usually with this stable angina, there are no symptoms at rest, no symptoms at rest, and symptoms are predictable with exercise. So people who have stable angina, they know if I walk up 2 flights of stairs, I start getting chest tightness. If I walk 2 blocks, I start getting chest tightness. They know exactly how much exercise they can do before they start getting the chest tightness. The clinical manifestations tend to be chest tightness. They tend to get pain in their left arm. This goes up to the jaw, their left jaw, and they can become short of breath. Generally, when somebody has these symptoms and it's brought on by that exercise, if they rest, the symptoms resolve within minutes. So the important piece is that it resolves with rest. It's called stable angina because the blockage is a stable size and the amount of extra work that the heart needs to do is dependent on how much exercise is happening. The amount of extra blood flow that it needs is dependent on the exercise. So if there's a stable blockage, it's going to lead to a predictable pattern of signs and symptoms. The second type of angina, if there's stable, there is unstable. And you could probably maybe guess what's happening with unstable angina. If stable angina is predictable with exercise, unstable angina has very specific definitions. This is those typical angina symptoms happening either, and it only needs to be one of these, at rest. So if somebody normally has angina when they walk 2 blocks and then they start getting symptoms while they're sitting watching TV, that is unstable angina. That is not a predictable pattern anymore. So this could be at rest. It could be that less activity brought on the symptoms. So maybe they're normally able to walk 2 blocks and they started getting their symptoms after 1 block of exercise. So less activity before symptoms. And by definition, the first time that anybody has angina symptoms, it is unstable by definition. So if somebody walks 2 blocks and starts getting chest tightness and it's signs and symptoms of angina, by definition, that is unstable angina. Any other episode that they get where it happens after two blocks or 3 blocks, that would be considered stable. But a first episode is by definition unstable, even with exercise. The thought is that unstable angina is happening as a result of disruption of an atherosclerotic plaque that is leading to some of those platelets kind of blocking a little bit more of the vessel. So it's an acute change to that atherosclerotic plaque. Because of that, because unstable angina is seen as a disruption of the plaque, that has happened suddenly, this is a medical emergency. This is a reason that you need to go to the emergency room. So it's treated as med emergency. We treat it exactly like a heart attack, which would be the next level. I'll tell you how heart attacks are treated in a little bit, but they are essentially treated exactly like a heart attack. The third one is a heart attack. This is the third form of ischemic heart disease. This is again an acute ischemic heart disease. So these would be myocardial infarctions. So this would be disruption of an atherosclerotic plaque to the point that either A, there is so little blood flow that the heart muscle cannot sustain itself and it will die, or there is a completely blocked vessel and the heart muscle is getting no blood supply and that heart muscle will die. So this is a myocardial infarction. This presents slightly differently. This presents with, and my word choice here is very deliberate. It presents as severe, crushing chest pain. People describe this like an elephant sitting on their chest. So they are really short of breath. Sitting on chest. People who are having a heart attack will often describe this severe crushing chest pain happening at the same time as them profusely sweating. They will sweat. The medical term for sweating is diaphoresis. So we would say they are diaphoretic. When anybody comes in and they have both of these, they have chest pain plus sweating, even if it's not super severe crushing chest pain, if I see sweating and chest pain together, I need to rule out a heart attack. And it's usually a heart attack. Both of these things equals bad. So they will be short of breath. The term for shortness of breath is dyspnea. The suffix pnea means breathing. And then whatever comes before is talking about what the breathing is like. So dys means deranged or abnormal breathing. And then pnea means to breathe. If somebody has apnea without breathing, okay? If somebody is breathing fast, remember tachycardia? If somebody's heart is beating fast, it's tachycardia. Tachy is fast. So we just put tachy tachypnea. Tachypnea is breathing fast. In this case, it's dyspnea or shortness of breath. People who are having a heart attack have, and this is in most of the medical textbooks, they have this thing called an impending sense of doom. In some cases, depending on which blood vessel is completely blocked off or mostly blocked off, it can present with nausea and vomiting. And this is especially true in females. It does happen in males. And nausea and vomiting in an older person, I will always rule out a heart attack in that person. I won't just say, oh, it's food poisoning or they're just indigestion. No, it is a heart attack until I rule it out. Because sometimes that is the only manifestation of the heart attack. Okay, that's a really important piece here. Nausea and vomiting in somebody who is older you need to rule out that it's not the heart. When we try to diagnose any type of ischemic heart disease, it really depends on the form of it. If it's a chronic form, we can do it as an outpatient. If it's an acute form, we have to do it in the emerge. So the investigations are dependent whether it's a medical emergency or whether this can be done as an outpatient. So say for stable angina. Stable angina. There we go. We'll do something called an exercise stress test. Essentially, someone needs to walk on a treadmill, ride a bike, while they're hooked up to all these monitors, while they're hooked up to an ECG to look for changes as well as symptom onset. When do their symptoms happen? And when they do happen, what's happening to their heart? So exercise stress test, we will do an ECG. We're going to measure blood pressure. We're going to measure cholesterol. And we're going to check blood sugar, blood glucose for diabetes mellitus. That's how we sort of work up stable angina for the most part. Now, if it is either unstable angina or a heart attack, this is done more in the hospital setting, in the emergency room setting. So unstable / myocardial infarction or heart attack. The main goal here is to improve coronary blood flow as soon as possible So what we will do in this case, what we're going to do in this case is we're going to work them up at the same time that we're going to try to give medications to improve flow. But in order to diagnose this, we need to do an ECG. Okay. We are going to do blood work. And this is actually a very interesting thing, blood work. There are a couple of proteins that we actually find within the blood. When heart muscle cells start to get damaged and destroyed, they start to break open. And the proteins that are inside of those heart muscle cells start to go into the bloodstream. We don't see these proteins in the blood unless there is damage to the heart muscle. And the two proteins that we look for, there's actually only really one that we're most concerned about here. The first protein that we only see in cases of cardiac muscle cell damage is something called a troponin. And the subtype is troponin T or I. This is specific to the heart. And then there's another protein that we look for called CKMB, creatinine kinase myocardial band. That's what it stands for. This is also relatively specific to heart. These will generally only go into the bloodstream if there's myocardial damage. Only in blood. Otherwise, when we check for them, if there's no heart problems, there's no actual damage to the heart muscle cells, we won't see this in the blood. Only in blood if heart muscle damage. So if someone's not having a heart attack, these protein levels will be normal. So as I mentioned, we're going to improve coronary blood flow. I kind of got ahead of myself there with that one. It's more for the treatment here. We're going to improve coronary blood flow for both stable angina and unstable angina and heart attack, there are many medications that we will use. The first ones are going to improve coronary blood flow. One of them is a group of medications called vasodilators. The one that's usually used is this pink spray that they put under the tongue, and it's called nitroglycerin spray. Sometimes people just call it nitro spray. So people who have stable angina, they'll sometimes have their nitro spray with them. If they get symptoms, they'll take a spray under the tongue and their symptoms will usually improve. This causes the smooth muscle of the coronary vessels to relax, and it will open up the coronary vessels more than they would have been able to open up. The second type of medication is kind of interesting. We can use beta blockers. Beta blockers. Remember, it slows the heart rate down to increase coronary blood flow. This one is a weird one to think about. So remember when we talked about our coronary blood vessel flow and how the coronary blood vessels filled during the relaxation phase of the heart? By slowing the heart rate down, the amount of time that the heart is spent in, the ventricles are spent in their relaxed state increases. So that means there's more time for the coronary vessels to fill by reducing the heart rate. Decreased heart rate equals increased time that the ventricles are in diastole. And this means increased time for coronary filling. We can do surgical things as well. The surgery that we do, there's two of them. Surgical. One is minimally invasive. This is, we can put stents in the blocked vessel. Okay. Essentially, they feed a wire through either your radial artery or your femoral artery. They go all the way through the heart, where the aorta is, where the coronary vessels come off of the aorta. They feed the wire through, and they'll find the blocked vessel. There will be a balloon on that wire. They will inflate the balloon, and around the balloon will be a metal stent, and it will keep the vessel open. It'll balloon open that vessel. In order to know what vessels are blocked, there is one other investigation that has to be done. And so you have to actually get a picture of the coronary vessels, and this is called an angiogram. Specifically, an angiogram that is of the coronary vessels, we call it a coronary angiogram. And they essentially inject radioactive dye and take x-rays to see where does the radioactive dye stop flowing. And where it stops flowing, there's a blockage in the vessel. So they'll feed the wire through to that blockage, balloon it open, and put a stent there to keep it open. The other surgical technique that is used is an open heart technique, whereby they do bypass surgery. They bypass the blockage. This is called a coronary artery bypass graft. Sometimes it's called CABG or cabbage for short. So when you hear people, oh, I had a quadruple bypass, I had a triple bypass, I had a double bypass, that is what they're talking about. Essentially what they're doing is they're taking the coronary artery where there is a blockage in the vessel. So there's a blockage in the artery wall. There's an atherosclerotic plaque that kind of blocks a lot of the vessel. And instead of, we'll just say it's going to block like most of it. We'll say that. It doesn't get very good blood flow. So what they do is they take a vessel from your leg and they'll make a little bridge over top of the coronary vessel. Oh, here we go. Oh no, that right there. Well, they'll make a little bridge over top of it. So the blood, as it flows through, will go over this bridge and around the blockage. So this would be a vein taken from the leg. And they'll put these bypass grafts anywhere where there's significant blockage. So cabbage, you can do stents. And then there's the important piece of thinning the blood. Thinning the blood meaning that the platelets are not likely to aggregate. So if there is any damage to a atherosclerotic plaque, the platelets are just going to stay on their own. So we thin the blood. The two big ones here would be the platelet, the ones that affect platelets. So we're going to try to reduce platelet aggregation. One of those medications is aspirin. Aspirin, when used in a high dose, acts as an anti-inflammatory medication. Some people used it for headaches and inflammation, but it also has a secondary effect of reducing platelet aggregation. And the mechanism of that is it blocks a specific molecule called thromboxane A2, blocks it. And thromboxane A2 is an essential factor in platelet aggregation. The thing about thromboxane A2 inhibition from aspirin is that the dose required to get that thromboxane A2 inhibitor is much lower than the dose that you require for the anti-inflammatory. So because the dose is very small that we give, they often call it a baby aspirin. Not because it's for babies. You should never give aspirin to babies ever. It increases risk of a neurologic condition. But it's called a baby aspirin because the dose is low. Not because it's for babies. Never give aspirin to babies. It's very dangerous. The dose of aspirin is 81 milligrams per pill. 81 milligrams. That's a baby aspirin. The second one is a medication called clopidogrel. It's also a platelet one. It's called clopidogrel. The trade name of this one is called Plavix. And it also reduces platelet aggregation from a different mechanism, though, not a thromboxane A2 mechanism. Often people who are having heart attacks will be on both of these medications. People who have stable angina will often take a baby aspirin every day. The other thing to do is to treat the risk factors. Lifestyle and treatment of risk factors. So, lower blood pressure. If the blood pressure is high, give medications to lower it. Control blood glucose. if diabetes. Treat high cholesterol. Exercise. Initiate a healthy and balanced diet. Exercise, and then this could also be lose weight if overweight. And then last but not least, you probably guessed it, stop smoking. I think we'll stop there today. That's a lot. Little bit about blood pressure, a little bit about ischemic heart disease, but there are a lot of nuances to this. Hopefully this gives you a good overview. Um, as always, if you have questions, please reach out and ask, and I'm happy to talk about this further with you. Stop there for now. We'll probably get into the respiratory system next time. I think that's our next unit. So until then, have a great week, everyone. Bye.